right, now we're going to talk about the cardiovascular system. And as you can see, we have a picture of a square heart here. All right, now I know you didn't know the heart is square, but it is. You've got to understand the normal blood flow through the heart, and I have that written out in your packet somewhere, okay? But here, just listen to me for a second, okay? Blood comes from the venous system, okay, and comes into the right side of the heart. And you know, the amount of blood coming into the right side of the heart, that's your preload. The amount of blood coming into the right side of the heart is preload. And it goes right atrium, right ventricle, down into the lungs where it gets oxygen. Then it goes back way over here to the left side of the heart. The left side of the heart is the big bad pump. Okay, that's the strongest part of your heart. It goes left atrium, left ventricle, and out through the aorta, which is the first and largest artery in your body. First and largest artery in your body. And then the aorta, it's the beginning of the arterial system. Arteries go throughout the body delivering oxygenated blood, and when all the oxygen has been pulled out of the blood, it ties back into the venous system and the process starts all over again. Okay? Now, if you have got, just look at the right side of the heart for a second. If you have right-sided heart failure, what does that mean? Right-sided heart failure means that the blood is not moving forward. All right, so if you look at the picture, if the right side of the heart normally pushes blood forward into the lungs, doesn't it, by looking at the picture. However, if it's failing, blood's not moving forward, so it's going to start going backwards into what system? Venous system. You see, some people think, well, the right side of the heart's failing, so the blood's going to back up to the left. That can't happen unless you have a hole in here somewhere, in between the septum, in the septum that's separating the right and left side. Now, look at the left side with me for a second. If the left side of the heart is not pumping properly, if you're going into failure, that means blood's not moving in what direction? Forward like it should. So it starts going backwards into my lungs. So that's why you've got to understand the normal blood flow of the heart, or you'll never understand right and left-sided heart failure. Now, also you have on your handout how to assess cardiac output. Cardiac output is one of the most important assessments you will do. And I've got your formula out there. Cardiac output equal heart rate times the stroke volume. Okay? And if you don't understand cardiac output and heart rate and stroke volume and how they're all intermingled together, we have two little sections there written in italics that you can read sometime, okay? That's if you want to understand that more. That's an excellent way to help you understand what's going on, okay? Now, I'm going to talk just in general about cardiac output. So come on down where it says, if your heart is weak, what will happen to cardiac output? Increase or decrease? Decrease. If your cardiac output is decreased, will you perfuse properly? No. Will you perfuse your brain very well? No. So your LOC is going to go down. Will you perfuse your heart very well? No. So your patient's going to start complaining of chest pain. Will you perfuse your skin well? No. So how's the skin going to feel? Cold and clammy. Well, if the blood's not moving forward, it's going to back up into my lungs, and now I have wet lung sounds. If I'm not perfusing, what's going to happen to my peripheral pulses? Decrease, maybe even be absent. Am I going to perfuse my kidneys? No, so my urine output's going to go down. All right, from this point forward, when you think about cardiac output, I want you to think left ventricle. Think left ventricle. How much blood that left ventricle is pumping out to the body. Now, before I read the next sentence, let's pretend that my heart rate all of a sudden, for whatever reason, dropped to 30. Am I pumping out as much volume out here to my body as I used to? No. So what's right then, what is going to happen to my blood pressure right then? Drops, because less volume, less pressure. But I have compensatory mechanisms that kick in, so later my blood pressure will hopefully come back up to at least 90, I hope, because you've got to have at least a 90 blood pressure to perfuse vital organs, don't you? Yes. So initially, blood pressure drops, but the compensatory mechanisms kick in and bring it back up to 90. Now, before we move on, there are lots of things that can affect your cardiac output. Let me just talk. This isn't on your handout. I'm just talking now. Well, we've already said that if your heart rate drops out the bottom, cardiac output just went down. What if for some reason my heart rate jumped up to 250? Watch my heart. Do my ventricles have time to fill? No. So extreme tachycardia, cardiac output just dropped. Now, here's my rule with arrhythmias. Here's the rule. Arrhythmias are no big whoop, W-H-O-O-P, until they affect your cardiac output. Arrhythmias are no big whoop until they affect your cardiac output. Nobody even cares about your arrhythmia that you're walking around with until your cardiac output is affected. Now, y'all, this is why that sentence that I just said is why VTach, VFib, and asystole are big whoops. Because when you have VTach, VFib, or asystole, do you have any cardiac output at all? None. That's why they're big whoops. You can have a patient in one room in atrial fib, and they're sitting up in the bed flipping the remote, oriented ×3, skin warm and dry, good blood pressure, etc. Are they tolerating their rhythm? Yeah, so it's no big whoop. But this person over here goes into atrial fib, and they get all confused. Their lungs get wet, they get cold, their blood pressure drops. Are they going to be able to stand it? No. So my point is this. If you ever have to call a doctor about a rhythm change or anything heart-related, the first thing they're going to want to know are these things we have listed on your handout. The signs and symptoms of adequate cardiac output. That is your pertinent cardiac assessment that they want to know about. All right, now then, let's look at chronic stable angina. Chronic stable angina. Yes, the long-term blood pressure. Okay, let me say it again. When cardiac output drops, okay, that's when you don't have as much volume coming out here, so less volume, less pressure, blood pressure drops. But long-term, you know, when the compensatory mechanisms kick in, that's when your blood pressure should come back up. We hope it comes back up to at least 90. All right, now then, let's look at chronic stable angina. This is decreased blood flow to the myocardium, which leads to ischemia or necrosis. Which one is it? Ischemia, which leads to pain and pressure in the chest, and it's usually caused by coronary artery disease. Now, what brings this pain on? Low oxygen, usually due to exertion. Low oxygen, exertion. And what relieves the pain? Rest and or nitroglycerin. Rest and or nitroglycerin sublingual, we're talking here. So let's talk about nitroglycerin a little bit. It causes venous and arterial what? Yes, dilation. Vasodilation. And this result will cause decreased preload and afterload. Well, that's good, because if you can decrease preload and afterload, what did you just do to workload? Decreased workload. That's very important with heart people, to decrease workload. Nitro also causes dilation of coronary arteries, which will increase blood flow to the actual heart muscle, also known as the myocardium. That's good. We want to get more blood going to the heart muscle, because if you can get more blood going to the heart muscle, that blood's going to take more what with it? Oxygen. That's what the heart needs. Take 1 every 5 minutes times 3 doses. And teach the client to remove the cotton from the container as it absorbs the drug. Is it okay to swallow your nitroglycerin? No. You know, absorption is different in different parts of the body, isn't it? We want it under the tongue for rapid absorption because under the tongue is very vascular. Keep in a dark glass bottle, keep it dry, keep it cool. And it may or may not burn or fizz. Y'all, the usual thing we think of here is this. When you put nitroglycerin on the tongue, we tend to want it to burn because we know that means it's new and in date and it's fresh. Okay? If it doesn't burn, depending on the drug that you're on, it may be out of date. But not all nitroglycerin products will burn. It just depends on which one you're on. The patient will get a what? Headache. Renew how often? Every 6 months is average. And after nitroglycerin, what do you expect the blood pressure to do? Drop. But let's think NCLEX, y'all. When you give somebody nitroglycerin, I know their blood pressure is going to drop because it vasodilates them. And then we always come back in 5 minutes and recheck their pressure and see how their pain is. On this test, though, you never leave the patient because when you're messing with somebody's blood pressure, are they stable or unstable? Unstable. You've got to stay with them. You've got to forget what you've seen done at the hospital. Yeah, their blood pressure's supposed to drop, but it's supposed to come back up. In some people, could it just keep on bottoming out? That's what we're scared of. That's why they want us to stay with them, to make sure it does come back up again. Beta blockers are given, okay? We've listed for you several examples there. What do beta blockers do to blood pressure, pulse, and myocardial contractility? Decreases. Decreases. And what does this do to the workload of the heart? Decreases. Calcium channel blockers. If you had to guess, what would you think that these did to the blood pressure? Decreased it. Because you're never going to give a heart patient something to pump up their pressure, now are you? No, you're going to throw them into an MI. Now put a star by the next sentence. They also dilate coronary arteries. That's a good thing. Enhancing blood flow to that heart muscle. And also, our chronic stable angina patient may be put on aspirin. That just has an antiplatelet effect, doesn't it? Patient education is next. Avoid isometrics. Those are exercises that make your muscles squeeze or tense up, like lifting something. Avoid overeating, rest frequently, avoid excess caffeine or any drugs that increase the heart rate. Wait 2 hours after eating to exercise. Dress warmly in cold weather, but any temperature extreme can precipitate an attack. Hot weather too, right? What if your patient, your angina patient, drinks a big, tall, frozen strawberry daiquiri really fast? Could that precipitate an attack? Yes, any temperature extreme. Take nitroglycerin prophylactically. You know, these people learn when they're going to have chest pain. If they see a flight of stairs, they know if they go up that flight of stairs, they may have chest pain. So they need to sit down and take their nitroglycerin, don't they? Why do I say sit down and take the nitro prior to walking up the stairs? What's the deal with sitting down? I'm going to get dizzy, aren't I? Yeah, I could fall. That's a safety issue. Stop smoking, lose weight. Smoking cessation is very, very, very important. The number one thing to remember with this person is to do everything you can to decrease the workload on the heart. All right, now we have acute coronary syndromes like MI or unstable angina. You know, as your angina gets worse, it gets more unstable, more unpredictable. You used to know what was going to bring your angina on, but the closer you get to an MI, the more you don't know what's going to bring your angina pain on. Now, this is decreased blood flow to the myocardium, which leads to ischemia, necrosis, or both. Both. You have both ischemia and necrosis here. Now, does the patient have to be doing anything to bring this pain on? No, they may be asleep. I bet your teacher told you that a lot of MIs occur in the early morning hours, right? Yeah, when people are coming out of REM sleep. When you're coming out of REM sleep, that's a very stressful time, and so a lot of people have MIs during that time, okay? Now, will rest or nitroglycerin relieve this pain? No. So signs and symptoms, pain. The classic picture, pressure in the chest. Pressure, pressure, pressure. With radiation to the left side, right? Yeah, radiation to the left side. But you know, everybody's different. Some people may just have pain in the left jaw. Other people have very atypical signs of an MI. I've seen women that presented to the ER and the only thing they were complaining of was back pain. I saw a gentleman one time that the only thing he was complaining of was bilateral elbow pain. It was full-blown MI. Or you see people that just have indigestion, or people that faint, okay? So the classic picture is the pressure, okay? But there's other ways people can present too. All right. Now, cold and clammy and the blood pressure's dropping. Well, if you see any of those things, I know that my cardiac output is going down. White count and temperature are increased due to inflammation. EKG changes. Yeah, your heart is irritated, isn't it? Very irritable, and vomiting can occur. Anytime you have somebody in tremendous pain, they may start to vomit. Because when you're in a lot of pain, the vagus nerve can be stimulated, which drops your heart rate. And when you've dropped your heart rate, you don't have blood going to your GI tract, so people get nauseated and they begin to vomit. Now, what are the cardiac enzymes that are drawn? Well, it must be the CPK and the LDH. But what do we call those things that I have in parentheses? Isoenzymes. Those are the isoenzymes. You've got to have the isoenzymes, because if you just get the CPK and the LDH, that's not going to do you any good. Now, which isoenzyme is the most sensitive indicator of an MI? CKMB. That's an isoenzyme, CKMB, because that means heart muscle is damaged. Heart muscle is damaged. Now, we also have the troponin there. Now, this is my favorite heart test of all. Cardiac biomarker, cardiac marker, it's sometimes referred to. Now, the reason it's my favorite is because it has a high specificity for myocardial cell injury. It's always normal in non-cardiac muscle diseases. You see, y'all, with the CPK, if you've been giving me IM injections, that can make my CPK go up. Nothing else can make your troponin go up except heart stuff. That's why it's our favorite. Elevates sooner and stays elevated longer. Can be detected 3 to 6 hours after onset of chest pain and can last 6 to 8 days after heart damage. Now, which enzymes or markers are most helpful when the patient delays seeking help? LDH and troponin. LDH and troponin. LDH is your enzyme. Troponin is your marker. And you can just put you a star by troponin because that's our favorite. Now, treatment. When a client presents to the emergency department with any form of chest pain, you give them an aspirin right then. That is a standard. Anybody who's complaining of any kind of chest trouble, you just go ahead and give them an aspirin right then. Antiplatelet effect. All right. If you're in the middle of an MI, what is the drug of choice for pain? Morphine. Given how? IV. Now, yes, it is going to relieve my pain, but it's going to do something else even more important than relieve my pain. It's going to vasodilate me. Vasodilate me, which immediately does what to the workload on my heart? Decreases workload immediately. That's more important than the pain relief. Decreases workload immediately. Your teacher told you that time is muscle, right? So the most important thing is to hurry up and relieve workload to save what little muscle they might have left, okay? Now, the next question says, who greets every patient with chest pain? Mona, M-O-N-A. Mona, M-O-N-A. Morphine, oxygen, nitroglycerin, and aspirin. Morphine, oxygen, nitroglycerin, and aspirin. That's just another general statement about people that present to the ER in chest pain, and that's in no specific order. That's just to help you remember the most important things. Now, what untreated arrhythmias will put the patient at risk for sudden death? VFib. That's your main one. That's the one we see most frequently due to the irritability in the heart. But other ones can cause sudden death too. Pulseless V-tach. Pulseless V-tach. See, you can have V-tach with a pulse. So pulseless V-tach and asystole. Pulseless V-tach and asystole too, but put a star by V-fib. And when somebody goes into V-fib, what had you better hurry up and do? Defib them. Don't delay. Because we've already said that the longer you wait to shock somebody, the greater the chance it's not gonna work. Early defibrillation. Now, what drugs are given to treat this? I'm talking about these arrhythmias that can lead to sudden death. Lidocaine is one. And amiodarone. A-M-I-O-D-A-R-O-N-E. All right, now, what is a sign of toxicity with lidocaine? Any neuro change. Any neuro change. So anytime you've got somebody on lidocaine, you better be doing neuro checks. Now, the good news about lidocaine is this. It has a very short half-life, which means that if they do start having neuro changes and you can pick up on it early, you can either decrease the lidocaine or get the doctor to switch into something else, and it gets out of their system really, really, really fast. All right? Now, what is an important side effect of amiodarone? The major one to remember, hypotension. Hypotension. And also you can put out to the side other arrhythmias too. Other arrhythmias. Now, what are you worried about with other arrhythmias? Decreased cardiac output. Decreased cardiac output. Remember, I just said a little bit ago that arrhythmias are no big deal until they affect your cardiac output, right? All right. All right, now, somebody's coming into the ER and they're having an MI and we put them in the head-up position. That's very important because that's going to decrease workload on the heart, decrease workload, and increase cardiac output. Decrease workload and increase cardiac output. Now, here's the deal with that. When you are lying flat, that's a stress on your heart. Because that, due to the nature of the way the heart sits in the chest, when you're flat, you're pumping uphill. Well, if you're pumping uphill, what's happening to your workload? You're increasing workload. That's bad. That's why you sit people up, to decrease workload on the heart. All right, PCI is percutaneous coronary intervention. This includes all interventions such as PTCA, angioplasty, and stents. All right, now the major complication is going to be an MI. That's the first thing I want you to think of, MI. But also we can't forget bleeding. Bleeding. Now, angioplasty, under angioplasty, I want you to know that this can be used for single and double vessel disease. Single and double vessel disease. Also, under PCI, it says if any problems occur, they're going to surgery. Okay? That's the first thing we need to know. Chest pain after procedure, call the doctor at once because that means they are re-occluding. These are just basic things you have to know. Now, coronary artery bypass graft will be done with multiple blockages, or if the patient has a left main occlusion, which supplies the entire left ventricle. Think about it, y'all. If the left main is occluded, then the left ventricle is getting nothing. So what is going to happen to it? It dies, and do you have any cardiac output now? Zero. Sudden death. All right, rehab now. Smoking cessation again, very important. Stepped care plan where they increase their activity just a little bit at a time. Diet changes, no fat, no salt, low cholesterol. You know, they tell these people when they go to the grocery store to only shop the perimeter of the grocery store. Don't go down the aisles. Because when you start going down the aisles, what are you getting into? High fat, trans fat, processed foods, high sodium. They want you to stay out on the edges with the fresh lettuce and broccoli and baked chicken, right? Right, baked chicken's always right on NLNs, isn't it? On your test at school, baked chicken. No isometrics because that increases workload. No Valsalva in heart people. Valsalva is bad in heart people because what nerve can be stimulated? Vagus. And when you stimulate the vagus nerve, your heart rate's going to do what? Drop. Hey, y'all, bradycardia is not that big of a deal. What's worse? Don't get me wrong, bradycardia scares me too because that just affected my cardiac output. But bradycardia can lead to what? Asystole. That really scares me, doesn't it? So you don't want them straining, no suppositories. We're going to give them Colace. Now, post-MI, people are always concerned about when they can resume sex. And they're worried about it, for one thing, because they're thinking, well, what if during sex my heart rate goes up, my blood pressure goes up so much I have another MI? Well, that's not going to happen, okay? That's a myth that the workload is that great, okay? But tell me when. What do you teach somebody about sex post-MI? When they can walk around the block or up a flight of stairs with no discomfort. Around the block or up a flight of stairs with no discomfort. You know, some people after an MI are scared to do anything. They just want to sit in their chair all day. They become what they call a cardiac cripple. They're scared to do anything because they're so fearful, okay? So that's something they may need counseling on. Now, what is the safest time of day for sex post-MI? Morning time. Now, I know what some of you are saying. You just said a lot of people have MIs in the morning. You just confused me. I said a lot of people have MIs when they're coming out of REM sleep, which would be 4, 5, and 6 o'clock in the morning. So for heaven's sakes, don't do it during REM sleep, right? You're going to have an MI. 8-ish or 9-ish will be fine. Best exercise for, well, let me say this. The reason behind the morning time is you want your patient to be well rested. Well rested. And the best exercise for an MI patient is walking. Walking. Teach signs and symptoms of heart failure. Y'all, now that I've had a heart attack, aren't I at risk? Yes, for heart failure. So you teach them things like ankle edema, shortness of breath, confusion, weight gain. Confusion and weight gain. All right, the next thing we're going to talk about are fibrinolytics now, okay? The goal is to dissolve the clot that is blocking blood flow to the heart muscle to decrease the size of the infarction. I mean, hey, if you got to have an infarction, you want a teeny tiny one, don't you? Yes, of course you do. So streptokinase, TPase, TNKase, it's a one-time push, Retivase. There's lots of other ones out there in the world. Now, let me ask you something. Out of all of these that I have listed here, which one do people have trouble with being allergic to? Streptokinase. All right, streptokinase. Allergies. How soon after the onset of pain should these drugs be administered? Within 6 to 8 hours. 6 to 8 hours. Now, don't get me wrong. The sooner the better, right? Now, if you said 3 hours, you're thinking about a stroke. the window of opportunity when somebody's having a stroke is much smaller than with an MI, okay? Now, let's think about that for a second. You know, when people start having the classic symptoms of an MI, they seek health care, don't they? Yeah, normally. They'll go and seek health care at the ER or whatever. Whereas when somebody starts having a stroke, people will just delay on that. I mean, think about it. If Mama is living at your house with you, they will let Mama walk around dragging her left leg tight with a thick tongue for a week before they ever do anything with her, right? Yeah, that's why they're thinking about changing the name of a stroke to a brain attack, so people will get more serious about it and act on it more quickly, okay? Now then, the major complication of a fibrinolytic is what? Bleeding is the number one thing to think of. So you got to get a good history. And I always tell people that you want to get a good bleeding history. You want to ask things like, have you had surgery lately? Stroke lately? Do you have a bleeding ulcer? Anything related to bleeding. Now is not the time to ask questions like, are you a diabetic? What about your mama? Is she one too? Okay? Now, nobody cares right now, okay, about your diabetes. We only want to know about blood stuff. Absolute contraindications are intracranial neoplasm, intracranial bleed, suspected aortic dissection, or internal bleeding. Because with all that stuff, can you bleed, y'all? Yes. Now then, during and after administration, we take bleeding precautions, which are listed on your handout down below. Now, let me tell you something. There are other times in life when we take bleeding precautions other than the fibrinolytics, okay? So let me give you some other times when these things are applicable, all right? When you are on heparin or Coumadin or Lovenox. Heparin, Coumadin, Lovenox. What about if you've got an alcoholic? Do you take bleeding precautions? Yeah, because what organ's messed up? Liver. You know your liver's very important for controlling bleeding. Tylenol overdose. Tylenol kills your liver, so you bleed. Hepatitis, cirrhosis, thrombocytopenia, any kind of bleeding problem. All right. When we start the fibrinolytic, we always watch the rhythm, and they're going to have some wild arrhythmias, and we call them reperfusion arrhythmias because, y'all, with the fibrinolytic, aren't we reperfusing the heart? Yeah, that's the plan, to dissolve the clot to reperfuse it. So you see wild arrhythmias on the monitor. How did I tell you, or when did I tell you to worry about an arrhythmia? When it affects your, yes, cardiac output. That's right. Draw blood when starting IVs and decrease punctures. You're trying to limit the number of puncture sites, right? Or they're going because if you give a fibrinolytic, you're going to bleed. Now, would it be smart to draw ABGs on somebody that's about to get a fibrinolytic? Not on NCLEX. Not on NCLEX, because arteries are high pressure and they will really bleed, won't they? Yes. Arteries are high pressure and they will really bleed. Don't get me wrong. They do it in the real world. That's why you've got to ignore what you've seen in the hospital, because that's a high-risk procedure. And NCLEX is about keeping people alive and limiting doing risky things to people. Okay. Now, antiplatelets are another important component of fibrinolytic therapy, and I've got several listed for you there that you may see out there in the world. And, of course, bleeding precautions would go with those things as well. Let's pretend we've got a patient coming into the ER having an MI. They do not have IV access. The doctor wants to start one of these fibrolytic protocols. Do you prefer an antecubital line be started or a central line? Ask your friend. What you think? Most people across the country will say central line because it just always sounds better, right? If they code, you've got a bigger line to push more drugs in more easily, that sort of thing. But y'all, what is the number one complication of a fibrinolytic? Bleeding. When somebody's bleeding from a site, what do? Hold pressure. If I've got a line up here, you're going to get fired if you get caught holding pressure up here on somebody. You just lost your little job, okay? So we prefer the antecubital because you must give fibrinolytics in a compressible site. You must give fibrinolytics in a compressible site. Hey, if somebody had a subclavian line and they started to bleed out, you couldn't even hold pressure anyway here, could you? Ribs are in the way, okay? Now, let's look at cardiac catheterization now. Pre-procedure, ask them if they're allergic to what? That's right, dye. Iodine, shellfish, whatever you want to put in the blank. Iodine, shellfish, because of the dye. And during the procedure, they may be asked to cough. That's why we do not like the patient to be completely knocked out during a heart cath, because they may need to cough for us, because that helps push the dye through the coronary arteries. Also, another thing that coughing will do is this. During the procedure, if the patient's heart rate drops, they can tell them to cough, and that'll make their heart rate come back up again. Okay, so we don't like for people to be completely knocked out. What is the hot shot? When they inject the dye. When they inject the dye. And that is a normal sensation. Anytime you are doing a test or assisting with the procedure where they are injecting dye, expect the patient to complain of being warm and flushed. You warn them about it ahead of time, though, because that's scary to people. They're wondering, why am I getting warm and flushed all of a sudden, okay? So you need to decrease anxiety. Palpitations are normal. I mean, you've got a catheter going into your heart, right? Post-procedure, watch the puncture site for what? Bleeding, hematoma. Even if it's just a little hematoma there that's getting bigger, you better hold pressure big time, right? I mean heavy pressure. Assess extremity distal to the puncture site. Remember the 5 P's from school? Pain, pallor, pulselessness. Put a star by that one. Should you have marked the pulses before they ever left? Yeah, you need to mark them because they may not be as easy to feel. And then you have paresthesia, and paralysis. Bed rest, keep them flat, keep that leg straight for 6 to 8 hours. They can ambulate after this, but y'all, even after the patient has passed the danger time, okay? In other words, you've gotten them, they're to the point where they can walk now. What is your number one concern still with the heart cath? Bleeding. Bleeding, bleeding, bleeding. Report pain as soon as possible, and the major complication is bleeding. Now, pacemakers are used to increase the heart rate when you have symptomatic bradycardia. Remember symptomatic, y'all. If I've got bradycardia and I'm not having symptoms, do they care about my bradycardia? No, it's only when you start having symptoms that they care about it. Now, pacemakers depolarize the heart muscle, and hopefully a resultant contraction will occur. Now, depolarization, as you know, is when the electricity is going through the muscle. If I walk over to an electrical socket and stick my finger in it, is my hand just going to stay like this? No, what's it going to do? Contract. That's what your heart muscle's supposed to do when it comes in contact with electricity. But just because you put electricity through somebody's heart muscle, does that mean it's going to respond every time? Pulseless electrical activity can occur. On the monitor, you can see a beautiful PQRST, but you cannot feel a pulse. Okay? That means the electrical part of the heart is working, but the mechanical is not. Okay? That's why your teacher always told you to treat the patient, not the Monitor, because the monitor looks like you're alive and everything's okay, right? But you're not if you have pulseless electrical activity. Repolarization. Now, the way I remember that is this. I say re equal rest. Re equal rest. That's when the ventricles are filling up with blood. Y'all, there has got to be a period of time where your muscle relaxes so it will have time to fill up again. You can't just, you cannot live if your heart is just in a constant state of contraction. It's got to release and relax so it can refill. 3 types of pacemakers: temporary, permanent, transcutaneous. A demand pacemaker is going to kick in only when the patient needs it to. So if I have a demand pacemaker of 70 and my own rate is 70 or above, what is my pacemaker going to do? Nothing. It's asleep, isn't it? Until my own rate drops below 70, and then my pacemaker is demanded to do what? Kick in and bring me back up to 70. Now, a fixed rate fires at a fixed rate constantly. It's okay for the rate to increase, but never decrease. Always worry if the rate drops below the set rate. That's just a rule that we're going to follow. Monitor the incision, and the most common complication in the early hours, electrode displacement. Displacement. You know, depending on the kind of pacemaker you have, different pacemakers have different wires going into different parts of your heart. Okay? So, and those wires have got to have time to embed into your muscle. That's why it says on your handout to immobilize the arm on that side. Because if you don't immobilize it, you know, if your patient's raising their hand, waving at everybody, could they pull out their wires? Yes, those wires have got to have time to embed. Signs and symptoms of malfunction is any sign of decreased cardiac output or decreased rate. Both of those are very good answer. The most definitive answer, my favorite answer, is a decreased rate. Decreased rate. So that's why we teach the patient to check their pulse every day. They need a little ID card that tells all about their pacemaker. They need to stay away from microwaves. You know, a lot of people say, well, that's old-timey. Well, there's a lot of old pacemakers out there and a lot of old microwaves in the world. MRIs, too. As you know, metal pacemaker and big magnets don't do well together, do they? No. A magnet can actually turn your pacemaker off. All right, and avoid contact sports. Well, a lot of people think that's weird. Well, there's a lot of young people out there in the world that have pacemakers, too. Now then, let's talk about CHF. It is a complication that can result from problems such as cardiomyopathy, valvular heart disease, endocarditis, acute MI. Well, you know, with most of those things, the problem is the blood is not moving forward for whatever reason. Like with a cardiomyopathy, I can just get that one day from a viral infection. I may go on a trip abroad and then come back with a viral infection and wind up with a cardiomyopathy where I'm not pumping well and end up having to have a heart transplant. All right. Now notice, we have left-sided failure and we have right-sided. When the left side of the heart is failing, the blood is backing up into the lungs. Think lungs here. Lungs, lungs, lungs. And so read over all your pulmonary symptoms I have listed for you. Got it? Left lungs. Now, when the right side of the heart starts to fail, the fancy word for that is cor pulmonale, okay? Now, when the right side of the heart fails, the blood's backing up into what system? Venous system. Venous system. So that's why you get enlarged organs, edema, weight gain, distended neck veins, and ascites. I bet your teacher told you that if you stay in left-sided failure long enough, you'll eventually go into right-sided failure, and that's true. But remember, people can have pure right-sided failure all by itself. If you have pure right-sided failure all by itself, the problem started in your lungs. That's right. Pulmonary hypertension. Pulmonary hypertension, like you throw a clot from your leg to your lungs, that made the blood pressure go up in your lungs, didn't it? So the workload on the right side of the heart just went up. Now, some new terminology that you may see. Systolic is when the heart can't contract and eject. We're talking systolic heart failure. Diastolic heart failure, ventricles can't relax and fill. All right, now, diagnosis. Well, one way they diagnose heart failure is with a Swan-Ganz catheter. It is a type of central line that measures pressures inside the heart. Well, let me ask you a question. If my heart is not pumping the blood out and forward like it's supposed to, what's going to happen to the volume inside the chambers of my heart? It's going to build up because I'm not pumping it out. More volume, more pressure. So Swan readings are going to go up. A Swan will help to determine the cause of decreased cardiac output. And then killer complications, you know, that's what I always focus on, right? Is what's going to kill you. Air embolus or a pulmonary infarction with a Swan. Those are two things you worry about. Now, an A-line measures blood pressure continuously on a monitor, okay? Now, an Allen's test is going to be done first, which is just to check for more circulation. And when you're studying at home, if you want to know the details on how an Allen's test is done, it's on your handout right there. That's as simple as it gets. It's just to check for more circulation because, y'all, where do most A-lines go? Into what artery? Radial artery. The radial artery feeds my hand, my fingers, right? So before you go and put a line in this radial artery, shouldn't you make sure that there's another pulse to feed the hand? Yeah, that's why they're doing the Allen's test, to make sure you've got good circulation if something is occluding your radial artery. Now, the doctor is going to put the A-line in, and the line is put in just like you and I start an IV. Now, when you and I get into a vein, and we get a blood return, we hook up our fluid, turn the fluid on, and if you're in the vein, it's going to start to flow in there, isn't it? When the doctor gets into an artery and we hook up the fluid and turn it on, is the fluid going to go in? No, because arteries are what kind of pressure? High pressure. High pressure. The fluid can't go in against the high pressure, so blood's going to start doing what? Back it up all the way into my bag if I don't do something. What have you got to do to the bag? Pressure cuff. When you have an A-line, a pressure cuff has got to be put on the bag of fluid. Pressure cuff has got to be put on the bag of fluid to force the fluid in against the high arterial pressure, right? Yes, to force the fluid in against the high arterial pressure. Y'all, if you didn't know that, could you kill somebody? How? They'd bleed out, wouldn't they? You'd come back in the room and your bag would be full of blood. All right, check distal circulation while in place. Put a line under the word circulation so you'll remember the things you're supposed to check there. Okay, my patient pulled out their A-line. What's the first thing you do? Pressure, because it's an arterial bleed, isn't it? Yeah, it's an arterial bleed. All right, also A-lines are usually put on an arm board just to stabilize it, okay, and it's usually curlexed in place. Some doctors suture them in place, some doctors do not. Now, another way that they diagnose CHF is with a blood test called a BNP. BNP. Secreted by ventricular tissues in the heart when ventricular volumes and pressures in the heart are increased. It's a sensitive indicator, and it can be positive for CHF when the chest X-ray does not indicate a problem. So that's a really good blood test that's done. Now, one thing about the BNP, if you've got a patient that's on the drug Nature Core, then you've got to be, this isn't on your handout, you've got to be sure and cut that Nature Core off 2 hours ahead of time prior to starting the BNP. It's drawing the BMP, I should say. It's got to be turned off for 2 hours. If you don't turn it off 2 hours before you draw your BMP, you'll get a false high. False high. All right. Chest x-ray with CHF is going to show an enlarged heart and pulmonary edema. Pulmonary edema. Echocardiogram, what does that look at? Yeah, ejection fraction, pumping action. It's actually a picture of the muscle, right? But with the echo, they can measure pressures in the right side of your heart and that sort of thing too. Also, a new classification system that you could see in a test question one of these days, New York Heart Association Functional Classification, okay? Classes 1 through 4, and the main thing to know about that is 4 is the worst, okay? And the only reason I had that in there is they could put something like that in the stem of a question, and you might think, oh, I don't know anything about a New York classification. You just got to think CHF, okay? Now, let's look at some treatment. We're all familiar with DIG. Now, DIG is controversial because it can increase workload on the heart, can't it? Yeah, and that's not necessarily a good thing to do when somebody is in heart failure. But if they're in atrial fib, they may use it because it'll control that arrhythmia. DIG will stop that atrial fib. Now, what does DIG do to your contraction? Makes it stronger. Well, that's what I mean by it's increasing the workload. That's why it's controversial with heart failure. What does DIG do to your heart rate? Decrease it. Decreases it. So, when the heart rate is slowed, this gives the ventricles more time to fill with blood. Okay, so think about it. Now we're squeezing down on more blood with a stronger contraction. Cardiac output just went up. Kidney perfusion just went up. And would diuresis be a good thing or a bad thing? It's a good thing because we always want to diurese heart failure patients. They can't handle volume. Now, they may start them on a digitalizing dose. That's just known as a loading dose. And all I mean by that is these first few doses are bigger than the maintenance doses. So it may scare you sometime when you see a doctor order a big dose of DIG. If it's the first few doses, we expect that because they're trying to build up a therapeutic blood level. Got to build up a therapeutic blood level. In normal DIG level, 0.5 to 2. 0.5 to 2. Now, how do we know DIG is working? Because cardiac output's going to go up. You always want the cardiac output up. That means that blood is moving forward. That's what DIG does, is makes blood move forward again. And as you know, you can get toxic on DIG. And I've got your early and late signs listed there on your handout. Early, anorexia, nausea, and vomiting. That's when they want us to pick up on this, in the early stages, before they have a bad arrhythmia like they can in the late. Arrhythmias and vision changes. I bet your teacher told you that when somebody's toxic on DIG, everything may look yellow. Or they may start seeing halos around lights. Well, what are you going to do if somebody calls you in the room that's on DIG and says, my room's purple? Everything just went purple. What are you going to say? Call me when it turns yellow? No, you're not going to do that. What are you going to assume? The worst. It's a vision change. They're toxic. Because my point is this. They're never going to put in a test question what you're most familiar with. You've got to learn to be flexible. Okay? Now, before administering, what do you do? Yeah, you check a pulse. What pulse? Apical pulse. Apical pulse. Now tell the person sitting next to you the exact location of the apical pulse. I heard you. Fifth intercostal space, MCL. Fifth intercostal space, MCL. You all memorized that for your cardiac checkoff, didn't you? Yes. But y'all, is it in the same place on everybody? No. What if I have left ventricular hypertrophy? Where might mine be? Shifted to the side, right? What if I'm 9 months pregnant? Where might mine be? Up here, right? My point is, it moves around on people. It moves all over the place. Here's a biggie. Monitor electrolytes. All electrolyte levels must remain normal, but potassium is the one that causes the most trouble. Write this formula down. DIG plus low potassium equal toxicity. That's the most common scenario. Y'all, could I get toxic on DIG if I had hyperkalemia? What did I just say on the handout? All electrolytes must remain normal. All of them. I'm just saying the one that causes the most trouble is hypokalemia. All right? Because I know in your books it's going to say something about hyperkalemia. All right? But the one that causes the most trouble is a low potassium. Now, other treatments for CHF, other drugs, diuretics. You got to get rid of that fluid, don't you? Yeah. We've already said that CHF people can't handle volume. We're diuresing them. We're decreasing preload. Aldactone may be given to decrease aldosterone levels. Well, that's a good thing, because if we can decrease aldosterone levels, I'm not going to hold on to as much what? Yeah, sodium in water. And when do we give diuretics? Morning time. You don't give them at night. You don't want your poor little patient up all night having to go to the bathroom. ACE inhibitors or beta blockers. Now, I've listed for you some examples of ACE inhibitors, okay? And I've listed for you some examples of beta blockers as well. Now, here's just a little rule that I've got here. If it ends in the word pril, then it's probably an ACE inhibitor. If it ends in lol, like propranolol, it's probably a beta blocker. That's just a little rule I go by. All right. Another treatment, low sodium diet. Once again, if you've got somebody who is taking in too much salt, what are they going to retain more of? Fluid and water. Not good. CHF, people can't handle it. Again, we're trying to decrease preload. And I told you that preload was the amount of blood returning to the right side of the heart, right? Yeah. So when you diurese people, you're decreasing preload. You're decreasing the amount of blood returning to the right side of the heart. We've got to watch salt substitutes, because salt substitutes can contain a lot of what? Yes, it can contain a lot of potassium, which can be dangerous too, right? And then canned and processed foods, over-the-counter drugs can contain a lot of sodium as well. Now, other information, elevate the head of the bed. You know, when we elevate the head of the bed, that's going to help do what to cardiac output? Increase cardiac output. Make blood move in what direction? Forward. And also do what will that do to workload on the heart? Decrease workload. Same reason for putting the 10-inch blocks under the head of the bed. Same stuff. Weigh daily and report a gain of 2 to 3 pounds. Hey, y'all, if you have a CHF person who gains too much weight overnight, that's fluid retention, right? And if you have a CHF person retaining fluid, what major complication are they headed towards that could kill them? Pulmonary edema. Pulmonary edema. And they need to report any signs and symptoms of recurring failure. So let's talk about pulmonary edema. Pulmonary edema. This is when the left ventricle has failed and blood is backing up to the lungs. So the patient is severely hypoxic. And when does this usually occur? Nighttime, when the patient is lying flat. Nighttime, when the patient is lying down. Think about that, y'all. Pretend I'm your CHF person. During the day, I'm either up walking around or I'm sitting up in my chair, right? So a lot of my blood pools in the lower extremities. But when I lie down, all of this leg blood can more easily make it back up into my heart and lungs. My heart may not can pump all that excess volume, so I go into pulmonary edema. All right, signs and symptoms. Sudden onset, breathless. The patient is restless and anxious because they're so hypoxic, right? Hypoxic, and a productive cough. I bet your teacher said in school, pink frothy sputum. Y'all remember that? Pink frothy sputum. Now, treatment, Lasix to decrease preload through diuresis and vasodilation. You see, y'all, you're already loaded up with too much fluid if you're in pulmonary edema. We got to get rid of some fluid. 40 milligrams IV push given over 1 to 2 minutes. You've got to be careful with Lasix, y'all. You do not want to give it too rapidly, because if you give it too fast IV, you can dilate people so fast that their blood pressure bottoms out. Now they're unconscious. The other thing it can do is if you give it too rapidly, you can kill your hearing nerve. Cranial nerve number 8, ototoxicity. Well, if Lasix is not working well, they may switch you to Bumex. This can be given IV push or as a continuous IV to provide rapid fluid removal. 1 to 2 milligrams IV push given over 1 to 2 minutes. Nitroglycerin IV, vasodilate, to decrease afterload. Now think about afterload, y'all. Afterload is the amount of pressure in your aorta here. Everybody look at my little picture. It's the amount of blood in, the amount of pressure in the aorta. That's what afterload is. Now, why am I emphasizing this? Because if you can vasodilate that artery, what did you just do to the pressure in that artery? Dropped it. You dropped the pressure. Well, if you're dropping the pressure in this artery, the aorta, how does the left ventricle feel? Better. It's like, oh yeah, I can pump against that little bit of pressure more easily. So when it's pumping against less pressure, can more blood get out? Absolutely. So therefore, cardiac output just went up. Cardiac output just went up when you decrease the afterload. Hey, if you're in pulmonary edema, wouldn't you prefer cardiac output increase instead of decrease? Yeah, because that's your whole problem in pulmonary edema. You've got too much blood going back into the lungs. If you can get more blood moving forward, that's going to be less blood going into my lungs. That's the name of the game here. We got to get things moving forward. DIG, some still use this to get the blood moving forward. Morphine, 2 milligrams IV push for vasodilation. See, once again, you're decreasing preload and afterload. That's a good thing, isn't it? NatureCore is an infusion, short-term therapy. Don't give it more than 48 hours, and it vasodilates veins and arteries, and it'll give you some diuresis too. Diuresis. Primacor, same thing. Dobutamine will increase cardiac output. Explain to the person sitting next to you how improving cardiac output will clear out my lungs. Come on, talk it out. Because you're making more blood go forward instead of backwards. Severe CHF. Cardiogenic shock, they may use the balloon pump. You know, cardiogenic shock is just pump failure, isn't it? Yeah, it's just wearing out. This decreases the workload on the heart and allows the weak heart muscle to rest. Now, if somebody's in pulmonary edema, you probably aren't going to have to tell them to sit up because they're already sitting up, gasping for air. But if they're not sitting up, sit them up, legs down. All right, that's going to improve cardiac output and promote pooling of blood in the lower extremities. Promotes pooling of blood in the lower extremities. Prevention, check lung sounds, and avoid fluid volume excess. Fluid volume excess. Cardiac tamponade. Cardiac tamponade. This is when blood has leaked into the pericardial sac. Think about that, y'all. The pericardial sac is what holds the heart, and it's filling up with blood on the outside of the heart muscle, right? That sac can only stretch so far, and it's going to start squeezing the heart. Don't forget that. It's going to start squeezing the heart. Signs and symptoms. Well, your cardiac output's going to decrease. CVP and blood pressure. Now, before I give you the answers to those, talk to me for a minute. Just for a second, let's pretend I've got somebody in a fluid volume excess. When you are in a fluid volume excess, the blood pressure is going to go up and the CVP is going to go up because more volume, more pressure. If I have somebody in a fluid volume deficit, my blood pressure is going to go down and my CVP is going to go down because less volume, less pressure. So do you agree that normally blood pressure and CVP like to do the same thing? Yeah, that's the norm for them to like to do the same thing. We got to mess it up here, okay? I told you that there was blood accumulating around the heart, squeezing the heart. If you are squeezing a balloon really hard, what's happening to the pressure inside the balloon? Increasing. If you're squeezing a heart with this excess blood, what's happening to the pressures inside? Increasing. So we have an increased CVP. Increased CVP. Now, y'all, I'm hemorrhaging into the sac around my heart. Anytime you're hemorrhaging, blood pressure goes down. So we have an increasing CVP and a decreasing blood pressure. That's not supposed to happen. They're supposed to do the same thing, and they're not. That's why those are two of the major symptoms of a cardiac tamponade. Heart sounds will be muffled or distant. Muffled or distant. Y'all, what is preventing you from hearing the heart sounds? Blood around the heart, right? Blood's in the way. Neck veins start to distend. And the pressures in all four chambers are the same. Well, that's weird, because you know you have different pressures in different parts of the heart. But if you're squeezing the entire heart, the pressures start equalizing. Everything starts being the same on the inside. Yes, they can go into shock. They can develop what's called a paradoxical pulse or pulsus paradoxus. Now, here's what that is. When the blood pressure is greater than 10 millimeters of mercury on expiration than on inspiration. The next thing we have is a narrowed pulse pressure, which is the difference in the systolic and diastolic blood pressure, which is the difference in the systolic and the diastolic blood pressure. So narrowed pulse pressure would just mean the difference is getting smaller, right? Like if your normal blood pressure is 120/80, your pulse pressure is 40. If you are getting a narrowed pulse pressure, it would start to go less than 40 is all we're saying there. And what they're going to do is a pericardiocentesis and surgery. Pericardiocentesis, well, they stick a needle in there to draw off the excess blood from around the heart. Well, how is that going to help? Well, it's going to help my heart to start to pump again. If you've got a bunch of blood around the outside of your heart, it cannot contract and relax. It's squeezed. And they can even open the chest and do an internal cardiac massage to pump for you until they can hurry up and get you to surgery. All right, let's take a little break.